Good morning, everyone. My name is Stefanos Zenios. I am a professor here in the business school, and I will be moderating our panel today with the theme Simplifying Healthcare. So before we start on the panel, I'd like to talk briefly why healthcare is so complex. And a lot of that can be traced back to the Second World War, when there were price controls and employers wanted to compete for talent, and they have figured out that one way to do that is by competing on benefits. And they came up with the idea of employment-based health insurance. Now, that creates a lot of interesting complications. You have access to health care only when you're employed. What happens between jobs? So in the magical wisdom of our policymakers, we invented Krna that enables you to continue your benefits between jobs as long as you will find your next job within 3 years. What if you want to start your own company or be self-employed? That creates some complexities. What if you're in a small company and then you find an insurer and one of your employees has a really catastrophic medical condition? The insurer may drop you and you will need to find another insurer. In economics, we call that adverse selection. So over the years, we had other solutions that emerged. Obamacare solved the problem of insurers dropping employers, of self-employed not having access to insurers. In the late 60s, we had Medicare that solved the problem of what happens when people retire. And then we had Medicare for people with disabilities and we cannot afford to work. So we have this patchwork of a system. Now that's from a system perspective. Now, if you think about that more deeply, when do we need health care? When we are at our most vulnerable, when we're scared, when something is happening that is really affecting your life, you go to see the doctor. There is a huge asymmetry. It's not the same as when you're purchasing something from Amazon and you can go somewhere else. You go to see the doctor. You may not be hearing something that makes sense, but you're scared, you're terrified. That adds another level of complexity. So how do we simplify healthcare? Today, we're very fortunate to have 3 leaders who are spending an enormous amount of time thinking and doing when it comes to how we can simplify healthcare. We have Krna right next to me. Catherine serves as the Ambulatory CEO of Greater Silicon Valley at Sutter Health, where she leads the team at the Palo Alto Medical Foundation in support of the whole group roles. In her role, she's responsible for advancing ambulatory care delivery and ensuring exceptional patient experience across the region. The region has achieved more than 5 billion patient visits in 2025. Right next to Catherine is Dredge. Carter is Executive Director of the Intermountain Health Institute and President of the Mindshare Institute, where he partners with top thinkers and doers to create novel solutions to complex problems and develop trusted and effective leaders. Carter has been recognized by Modern Healthcare magazine as one of the top 25 innovators in the United States, and he has served on numerous boards of health service organizations, insurance companies, and startups. And next to Carter is Catherine Field. Catherine is Senior Vice President and Medical Division Leader for Humana, a leading health and well-being company. She oversees Humana's Medicare HMO and PPO health plans, prescription plans, Medicare supplement policies, employer-based Medicare Advantage policies for eligible retirees, dual-eligible special needs plans, and private fee-for-service health plans offered to those eligible for Medicare. So in just that sentence, you can understand the complexity of healthcare. Catherine leads Humana's 25-state West Division, as well as Humana's group Medicare team, and over 1.7 million individual Medicare Advantage Part D members. So please join me in welcoming our panelists. Thank you for being here. So I have asked each of our panelists to talk about 7 to 8 minutes on something that is dear to their heart when it comes to an initiative that simplifies healthcare in the organization, and to reflect on leadership qualities that are needed from a leader who will lead such simplification initiatives. And Catherine will go first.
Well, first of all, Stefanos, thank you for that warm welcome to all of us on the panel. So again, Krna, the CEO of the Palo Alto Medical Foundation. How many of you have heard of PAM, or at least, okay, good, that's great. So I'll really talk today about the 1 million patients that we take care of each and every year. So Stefanos, the question that he asked each of us is to come up with not only an initiative that we're passionate about, but also a thesis that each of us believe to be the case about what you have to believe in order to simplify healthcare. So the way I translated the question is, there's nothing I don't think much of us, the 3 of us, can do to simplify care. Care, depending on what the patient needs, can often be very complicated, but we can do things to simplify, at least I feel, access to care. So that's how I translated the question. And I thought about simplification less around digitalization or adopting technology, and more about how can we offload cognitively the challenges and the emotions that our patients have and our clinicians have in caring for those patients. And so I'm going to talk about 3 initiatives that I'm super excited about that the Palo Alto Medical Foundation and Sutter Health have committed to in order to do that. So the first, and maybe a little bit about the thesis, too often times we structure systems to support patients or customers around ourselves, around our back office, what works for our organization or our structure. And my central thesis is once you start to organize things around the patient, you make their lives easier and better, and by extension, the physician. So 3 initiatives at Sutter that we are trying to activate and improve to live out that simplification. So the first is our online portal. It's called My Health Online. Like many healthcare systems in the country, not sure about Intermountain, it's based on Epic, which is the electronic medical records platform. But even though it comes from one company, Epic, there are things that you can do, and there's agency that systems have to make changes to that portal that really help patients, the unique needs of patients within the care environment. So Sutter has gone all in on that in our My Health Online. And so table stakes today is interacting with your doctor virtually, sending them a message. But what isn't table stakes is scheduling appointments, scheduling complicated appointments, getting proactively information based on your most recent visit with your physician that helps inform your next step. So there are a whole host of initiatives that we're employing and focusing on to really drive patients' channel of communication with us through that My Health Online. Now, it's not going to negate the need to come in and see your physician and have your physician lay hands on you oftentimes, but it's remarkable. And we've learned since COVID just how much can get done, certainly from a communication standpoint with your care team. So that's kind of like the first leg of the stool. The second thing is on-demand visits, so something that we activated a little over a year ago. So on-demand, that means that wherever you are, you can pick up the phone and schedule an appointment immediately to see a physician via video visit or through some channel, hopefully even on your phone. So lots of systems, again, across the country have done this. Many systems, however, have elected to partner with external third parties, very good external third parties, where that physician may be sitting in the state in which the patient is calling in from, but they also might be sitting across the country, depending on that third party's ability to overcome interstate commerce laws. What we've elected to do, because Sutter Health is so big, is actually leverage the physicians within our network to pick up the phone. So we have Sutter's about a $20 billion organization, about maybe the 10th to 12th largest in the country. We have the benefit of 7,000 physicians that are actively working in the state of California with us. So what we elected to do is to create that on-demand video visit. So you can go onto the Sutter Health website and click, yes, I need to see a physician, and I'd like to do so now, with the physicians that are a part and affiliated with us. And we did that for 2 reasons. One, it is often, even though a patient may come and see you episodically for something that they need right then and there, it's not surprising that most of those patients will come back, or even that video visit will trigger the need to go and get a lab draw, or maybe even an X-ray or an MRI. So we wanted to make sure that we could take care of the episodic, but that we also were taking care of the patient around their continuum of care, so that if they came to see us, even via the video visit, that we would be able to follow up with them. And then secondly, and we'll get into perhaps the topic of change management a little bit later, as I was interacting with my physicians around all of this, they had concerns. They had concerns about the quality of care. And it doesn't mean that they always have to provide it, but they wanted and they felt strongly that they would rather go through the change management challenges and the operational challenges of figuring out how we could do it internally together than partnering with a third party that might have made it easier for us from an efficiency standpoint on the front end, but wasn't really representative of the culture that we have. And the third leg of the stool is a little bit about the cognitive load for the physician. I'm a firm believer that happy patients make for happy doctors and vice versa. We were continuing to be focused on the joy of practice of our physicians, which before COVID, during COVID, and certainly after COVID is something that I'm sure all three of the panelists think about. It is hard to practice medicine, and they continue to hear physicians from people like me that I'm looking for greater degrees of efficiency. How can you see one more patient? How can you do one more thing? When most physicians, at least the ones that I know, went to medical school because they really want to take care of patients and they really don't want to be distracted by all of the sort of the administrative burden that we ask them to do. So a little over a year ago, Sutter Health partnered with a company called Dredge. For any of you who have come into the Palo Alto Medical Foundation or seen a Sutter Health doctor, chances are they might have said, patient, et cetera, do you mind if I use my phone today? It's going to ambiently listen to our interaction. And then when I get back to my desk, surprise, surprise, there is going to be a note that really focuses on the important part of our care interaction and really removes the 20, sometimes 30 minutes after the exam room visit that it's needed to really dictate that respective note. So I'll just say that I was a little bit cynical about this to begin with, both patients' comfort with it as well as the physicians really adopting it. And boy, was I wrong. So a year later, we have offloaded by about 20% the physician time after that interaction with the patient. And with very, very few exceptions, patients love it. Patients love it because the physician gets to look at them in the exam room visit and really focus on their care needs, as opposed to sitting behind a computer and typing, which doesn't feel like as intimate and as close as an interaction that the patients would like to have. So we are going all in, again, on simplifying the day for the physician so that he or she can really focus on what it is that they care to. So I'll end there.
Thank you.
Yeah.
Harder.
Thanks, Stefanos. Thanks, Catherine. So for those of you, if you know Intermountain Health, we're headquartered in Salt Lake City. We operate in 6 states. We have about 70,000 caregivers. We have a health plan, hospitals, and clinics. But what I'm actually going to be talking about is much broader than a system strategy. It's actually a national strategy that Intermountain is helping kind of sponsor and lead out in a very collaborative way. And it goes back maybe about 7 or 8 years ago. We were struggling with getting access to essential medications. You know, in any given quarter in the United States, there's about 250 essential medicines you may not be able to get. They're on shortage. And they stay on shortage for years at a time, some over a decade. And we were really struggling with how to figure this out. And we ended up coming up with a new approach. We created a company. It was called Civica RX. It's a nonprofit company whose primary goal was to ensure access to these affordable medications. And it just exploded in terms of growth. So when we launched the company, day one, we had 500 hospitals. No company, day one, 500 hospitals. We ultimately, at this point, have scaled up to around 1,500 hospitals. That represents about a third of the inpatient hospital capacity in the United States. And we have treated now approximately 100 million patients in a new model. It was so different, we didn't really know how to talk about it or how to explain it. I was serving as a chief strategy officer at that time of another health system in the Midwest, SSM Health. And I went to our CEO and our board chair, and I said, we need to understand this, because this is fundamentally, it can restructure how we do this and simplify things in a dramatically different way. And so I moved my family in the middle. I have 4 kids. My wife and I, we moved our kids to England, where I pursued a PhD at the University of Cambridge, and we moved in the summer of 2020. Rough. But we really wanted to try to solve this problem. And by intensely researching it, working with people all over the world, including here at Stanford, we figured out and we developed a model that we call the healthcare utility model. It's a fundamentally new business structure that, when implemented in mass, we believe will create an entirely new genre in healthcare to simplify it, related to building essential healthcare infrastructure. If I was going to simplify the problem of the American healthcare system into as simple as I can, the United States healthcare system is remarkable at producing novel scientific innovations, best in the world. Where we fall down as a system is making the old stuff affordable and accessible. And so we are actually designing structures that will actually inject new businesses, nonprofit, non-stock companies, to bring institutional entrepreneurship at scale to mature products. We actually refer to this as disruptive collaboration. So many of you think about this, and disruptive innovation at this point is a very popularized term. Silicon Valley is probably like the epicenter of disruptive innovation in many ways. We're talking about something different. What about if the product's not new? What about if the product's old? What about if it's a standard of care, and yet it's either not available or not affordable? That's where we apply this concept of disruptive collaboration, where we pool scale from numerous institutions to enter the market in mass and drive things down to a really low cost. So with all those 1,500 hospitals, exact same contract, exact same price. We have no marketing team, standard paper contract for everything. So once we developed this model, we did it again. This time in retail generic drugs, where we were having really high costs on cancer drugs. And we picked a prototype drug called abiraterone acetate. It's to treat metastatic prostate cancer. The brand name is Zydeco. And this was well off patent. It was $3,000 a month. And we talked with our teams and we're like, this seems like this should be cheap. They agreed. So we aggregated the scale. We worked with insurance companies. We partnered with 23 different insurance companies to collectively, that covered 100 million people in the United States. Collectively pooled the scale, partnered with some contract manufacturing organizations, and we dropped the price of this drug. We sell it profitably at $171, 90-something%. And then we looked at this and said, well, we need to do more of this. These businesses, we were doing it off the side of our desk. We had jobs. I was a chief strategy officer. Others were presidents of companies. And we said, we need to dedicate effort. So as I finished my doctorate work at the University of Cambridge, SSM and Intermountain got together and said, we got to figure out how to get more people involved. And there is a lot of people involved. Mayo Clinic, HCA, a bunch of these health systems. And let's do this on steroids. And so we formed a new institute called the Mindshare Institute. And the Mindshare Institute is dedicated to, our purpose statement is solving market failures that are hurting people. And it's really about finding areas where simplification is not only needed, but screaming. It's needed that bad. And we will inject these new entities into the market, and we ask a fundamentally different question. We don't ask, what is the highest price the market can bear? We ask a different question. We say, what is the lowest sustainable price we can deliver to the market? And in fact, as a former strategist, it was complex to say we are literally creating intentional commodities. But it's important because if we can do that well, what happens is we won't harm the novel innovation function. We need new drugs. We need cures for cancer. This isn't the model to create the cure for cancer. It's the model to have a well-established, generic, standard of care version of cancer, affordable, and accessible to everybody. That's what we're trying to do. Since forming the Mindshare Institute 15 months ago, we have launched 2 other national scale businesses. One of them is in an adjacency related to pharmaceuticals. I'm not at liberty to fully announce everything in there. We raised $100 million. We worked with institutions that cover 22 states, and we've launched that. And the other one that I can talk about is we've now started to breach into services. And we launched an air medical transport company called AeroTerra Health. The current air medical space, there's 2 private equity-backed companies that control about 2/3 of the market. And so we have instituted and launched a transparent, lowest net cost air medical transport, air ambulance company that anticipates that we will save billions of dollars for patients and society by streamlining, making the same terms for everybody. So in short, and what does it mean for a leader? We think more about market impact than market share. These businesses are actually designed never to be sold. There's no exit. They have to prioritize the collective benefit over individual competitive advantage. They have to be able to say, where is it where uniformity is desired more than differentiation? And we really have to align on patients. Last thing I'll say. By doing this, we fundamentally believe we can start to detangle this ball of yarn, which is the U.S. healthcare system, in a systematic way. There's critics that say, that's going to take decades. And I would say, true. But I believe it's possible. And we're seeing things now where we are giving patients, millions and millions of patients, access to things they never had before. And probably the thing we're most optimistic about is if we can do it that way, we can actually catalyze novel innovation rather than curtail it by a model that may not be as fit for purpose. So that's what we're excited about.
Thank you, Carter.
Catherine. I'm Catherine, another Catherine with a C. And, for any of you who, my mic, it's on, right? If you don't know who Humana is, besides that alphabet mouthful of types of products that were described, you are a health insurance company, a national health insurance company that is 100% of our revenue is in government programs. So 80% of our revenue comes from Medicare Advantage programs. We're in Medicaid, and then we're a TRICARE participant. So we are all things, all day government programs. And one of the things that I think, just not knowing all your backgrounds and the things that you do or do in your professional life or personal life, I know that 100% of you are consumers of the healthcare system. So you are officials on the complexity of the system, I guarantee it. And I think, Catherine, you maybe mentioned this, is the system was not really built around any one of our experiences, right? It was built around, I'm gonna offer this service, or I'm gonna offer this service. I'm gonna be a hospital, I'm going to be a specialist, I'm going to be a doctor, a lab, a pharmacy, you name it, right? We've got all these silos and these disparate goals, priorities, organizations that are serving a customer, but no one really looks at the holistic view of the consumer. And that has really, and maybe the other thing that kind of adds to some complexity that we haven't really talked about too much is the system is really built on a fee-for-service payment model, right? The more you do, the more you get paid. And so that motivation really sort of drives complexity, and it doesn't really solve for collaboration. And so they're really, one of the things that Humana is very, very focused on is consumer and improving the health of our members. And I think you can all appreciate and know this from your own personal experiences. When you have a lot of complexity, access to care goes down, quality of care goes down, and cost goes up, right? So the complexity is driving a lot of the low outcomes, high cost system that we have. And so there are really 3 things that Humana is very, very focused on to drive simplification in the healthcare system. And I'll probably get to maybe 2 of the 3, we'll see how the time goes, but the first one is I'm wildly passionate about is what we call value-based care, or aligning incentives in the healthcare space. And again, just perspective from Humana's lens is, with 80% of our membership, our almost 7 million members, are in the Medicare Advantage program, so are going to be over the age of 65 or older, or disabled. And again, you may know this for your own life or a loved one, is over the age of 65, 9 out of 10 individuals have at least one chronic condition, and 2/3 of the population have more than two. So when you think about that, that means I probably go to a primary care doctor, I go to multiple specialists, I have labs done probably a couple of 2 or 3 times even a week. This pharmacy, I'm going to have this surgery done. If I go to the hospital, I'm probably going to have to go to a skilled nursing facility afterwards. Then I'm going to go home. Like these handoffs throughout the system are a nightmare. And I will just share a really quick story. My mom is 95. She's in a memory care unit today. But at 85, she needed a surgery, and she was already fairly complex and fragile. And so I, as her very well educated in the healthcare system daughter, was like determined that we were going to make, because she was on a whole medication. Were kind of odd. She had some unusual history in her medical history. So it was really important that those medications like stay similar. Like, we're not going to, as she moves through the system, she needed them and needed to take them. And so she gets to the hospital, and I'm very, diligent with that, the hospitalist. I'm very diligent with the post-discharge people. She goes to skilled nursing. I'm very diligent with the post-discharge instructions. We're going to get to that system. Now we're going to talk about it with the system. I leave her that first night. I go home. I come back, and she's had a horrible night. She's had psychotic episodes. She's been up all night. She's frantic. Clearly, she is not in a state where her back surgery is going to improve, right? She's in a spot where she is very frantic. And again, it became a situation where the medication she was on, they didn't have it, so they substituted something else, and everything was given at night rather than kind of across the course of the day, yada, yada. And it's one of those stories that I think about all the time, because I am well educated in the business. I understand these managed care, and I've had many conversations, but nobody is spending time really looking at this holistically. And so the point I want to make here is, when you think about aligning incentives in a way that you're focused on quality outcomes and not just my little piece of the system, you're going to get somebody that is paying attention. The system is going to pay attention to what's happening to my mom through all those transitions of care, because her ending up back at the hospital or longer in that skilled nursing facility, or not getting home where she's probably going to have the best chance of getting well. You've got to have, aligned incentives help with collaboration. It is a fundamental way we pay, right? It's a payment model change. And we have these kinds of payment models, whether it's in primary care, specialty care, hospitals, a lot of innovation around payment. But kind of moving away from this fee-for-service model to one where we're focused on outcomes and improved quality. And I'll just give you a couple quick stats, and then I do want to talk a minute about technology, because I think, and data sharing, because that kind of goes hand in hand with this kind of structure. We've been in value-based care business for 25, 30 years. We publish a managed care report annually that looks at our population and compares the outcomes to original Medicare or to members that are only in a fee-for-service relationship. About 70% of our Medicare Advantage population is in some kind of incentive-based payment structure. 40% is in what is called a two-sided risk, meaning, well, if we between the provider and Humana, if we win together, we lose together. So that would be considered two-sided risk. And we publish this, organizations like the Association for Provider Groups, APG, they've published that when you see members in sort of two-sided risk deals or incentive-based models, you see improved, less ER utilization, right? Because people can go to their primary care doc. They're not going to the ER for care. There are less hospitalizations, improved quality and preventative care measures. You see more dollars spent on primary care than specialist or hospitalizations. And again, you're trying to get care in the right spot. You're trying to get coordinated care and care that's focused on clinical outcomes. And you see improved member satisfaction. And again, it's one of those where there's a lot of complexity to why don't we do more of this? Payment is difficult. The CMS model for payment in Medicare Advantage is challenging. There's a lot of challenges to the program in general. But we know that when we align incentives, care is delivered more effectively at the right location with the right outcomes. Tangentially is another area that we're spending a ton of time on is data. And because as siloed as care is, data is equally as siloed, right? And back in the, post, sort of part of the ACA, Obamacare, was that we were going to now, all medical records, we're going to massive investment as a country in electronic medical records. Fantastic. Less faxing. There's no less faxing today, I will tell you that. And what we've done is we've just continued to silo the data within each of those EMRs. And so the Center for Medicare, CMS, Center for Medicare Service and Medicaid Services, along with the White House, came out with their Let's Kill the Clipboard initiative last summer. It's their big focus on the healthcare technology ecosystem. And it's really about and at this point, it's very volunteer. But there's a lot of constituents in the healthcare sector that are about sharing data more transparently, being able to, and really a big focus is giving us as consumers access to our medical information. And so Humana recently partnered with an organization called Be Well. They're one of the large sort of aggregators of data. It's many hospital systems, providers, labs, pharmacies, health tech organizations, HEIs, these health exchange information systems, all that data going into one location. And then as a Humana member, I can go to Be Well and I can get really for the first time my own longitudinal health record, which is really exciting, right? Because I remember, 2 years ago, 4 years ago, I had those labs done, and I think they showed something weird, but I can't find that lab because I go to a different lab now, or I had we don't keep track of our health information very easily, and no system does. And so these kind of aggregating organizations and giving all of us as consumers access to our health information is going to be critical to, again, sort of simplicity in the system. So I don't have to find my mom's massive health record. I can access it through this particular vendor relationship. I will just stop there because there's just lots and lots of work going on here. You mentioned Epic. Lots of health plans are now partnering with Epic in new ways so that our information about our members are showing up in real time to providers. But I would just say that when you think about leaders in this space, and I think you both have hit on kind of some of the leadership qualities, is you really need leaders who are system thinkers, right? That they can connect the dots between all these disparate individual organizations so that I can understand what is the motivation between the hospital system and the provider and the lab, and what are the connecting dots within my own very complicated system. So you need people who are systems thinkers. You need people that are, I think you mentioned, strong communicators. And have an empathy for the part of the system that you individually don't control, so that I can understand what a partnership would really look like. And kind of, I think the leadership skill of the day, no matter where you are, is about being curious. And there is this element, I think one of the speakers mentioned it earlier, about sort of being a lifetime learner. But it is about being curious about how do we connect dots. And one of the things I'll just finally say is, in healthcare, as complicated it is, as many sort of dysfunctions and disparate goals, the common ground is always the member, the patient. And if we can stay oriented around the member and the patient, almost every negotiation that goes poorly or disparate goals or functions or focuses can melt away, because it is really about making healthcare simpler for all of us as we show up for ourselves, our parents, our kids, our neighbors. And so, again, I'm optimistic about lots of work here, but there is a lot of work to do, as you both have mentioned.
Great. Thank you all for your remarks. So as I was reflecting on your examples, I've heard a lot about examples that simplify individual steps in the whole patient journey. Scheduling an appointment. You reduce friction in scheduling an appointment. That's an improvement. Lowering the cost of generic drugs. That's an improvement. The story that you shared, Catherine, about your mom, these are the stories that we keep hearing. I have a very similar story with my mother-in-law. The doctors not realizing that some drugs had interactions because they were not part of the system. And then my wife figuring that out for her mom to make sure that she avoids those complications. A few years ago, we did a project with Stanford Healthcare on navigation for cancer patients. They developed a system where they had a navigator to help the patient navigate the complexity of cancer care. And they couldn't figure out the business model. The incentives were not aligned. And we tried to help them, and I put teams to work on that. We're not making progress. This last quarter, I had a team in one of my classes that worked again with Stanford Hospital to improve the discharge process. And what they found out is that there are about 10 to 15% of discharges that are getting delayed by at least a day because the DME equipment that the patient needs is getting denied by insurance because they filed the wrong form and you have to go back and forth. And now that may turn out to be 3 days if you're planning to discharge the patient on a Friday. So these are the stories that I keep hearing. How do we tackle these problems of interconnectedness, where value-based healthcare can provide the incentives? Sharing the information can provide some visibility. Where do we bring the collaboration between the different parts of the healthcare system? Humana alone is not going to be able to solve it. Intermountain is not going to be able to solve it alone. PMF is not going to be able to solve it alone. How do we create that radical collaboration?
You know, I'll start, and my panelists will make it better. I think, so one thing we talk about is, we talk about alternative payment models when we think about alignment, but I actually think deeper. I think about alternative production models. Not just aligning by contract, but aligning by construct, deeper. I think the incentives behind the incentives, I think, are also holding us back. When we think about data, I kind of think about like data is like water. The more it moves, the cleaner it gets. And right now, we definitely have cesspools of data. I think it's going to take a standard. I think we're going to have a semantic and syntactic data layer, almost like a platinum layer of data, that I think we need to remove the barriers of the digital adoption gauntlet, right? So, I mean, right now, like it could take 18 months to pilot a digital application in a healthcare context. That is untenable from an innovations perspective. So I think we need to, again, we have to hit structures. We have to create some sort of semantic and interoperable data layer, platinum layer. And then when it comes to collaboration, and I've been doing a lot of collaboration the past decade, and I honestly think that sometimes we have to not start at the absolute core, because people get chewed up. What I mean by that is, before we use the term disruptive collaboration, the draft version was called ancillary disruption. And it was this notion, the closer something is to the core of an organization's identity, the more likely they are of it has to be different, which actually continues to promulgate this everyone is a snowflake mentality that honestly we get massive amounts of non-value added variation in healthcare. So for us, at least my paradigm, is if we can pick meaningful but ancillary pieces to really drive the collaboration, really liberate the data, really align the incentives, and we start working our way in to the core. That's one approach. There could be people that have different opinion, but that opinion for me is where I've seen collaboration work at scale with hundreds of millions of dollars and really at this point thousands of stakeholders work for what it's worth.
Yeah, I think maybe just to add too is I do think it requires companies to have some staying power in these areas. You know, these things, you know, some of the core, I mean, because I love the work that your organization is doing, Carter, around just what are kind of these utilities in the healthcare sector. Because again, part of what shows up for all of us as that annoying claim that I can't ever figure out why it's not paying, is it the insurance company or is it the doctor, and they keep sending me back and forth. Or the annoying, I went to the directory and I couldn't see that provider. I know they're in, I know Sutter's in the network, but I can't find Dr. Jones and they work for Sutter, why aren't they there? Like this kind of, all of that is sitting underneath this layer of mess called credentialing, called doctors and
Provider
labs
directories of it.
and providers. People move around all the time. So people on my organization that are reaching out to their organizations for a roster, and it's coming in a form that looks different from every company, and if there's credentialing that's done differently, and these are things that should be done the same everywhere. We should have a uniform credentialing, we should have uniform roster management, we should be able to update these things instantly. That is stuff where there's a lot of common ground in the industry if we could get people to work together. And I think there is a willingness and a staying power that's required here, because these are all very large organizations that just, so I think there's a quality about companies that need to have some staying power, stay focused on the big deals, and really separate out the things that, to your point, where variation matters and then where it does not, where competition matters and where it does not. We should not compete on the accuracy of our directories. Like, they should just be accurate, right? And we should not compete on the credentialing process. Like, you're a doctor or you're not. I mean, it's kind of, again, it's more complicated than that. The point is, these are areas where there should be a lot of common ground, and we can get some momentum behind that. And that's what you're going to, because what's going to happen there too is there are some really interesting use cases with AI in this kind of space. And we should be able to take advantage of that, but we can't unless we have some uniform ways of looking at data. Then you can start taking costs out of the system in a way that is meaningful. Because I think part of the problem here is, in a moment in time where, again, in my world of government programs, there is not more money, there is less, right? As a nation, we spend, the debt pressure on us as a nation is putting pressure on our ability to spend in the healthcare space. We just need to stop the rapid increase of healthcare spend. If we can just slow it, we are going to be in a better spot. But you're going to have, so spending all this excess on things that don't matter would allow us to spend more on the things that do matter, which is access to care, better primary care, more primary care. So I just think, again, it's, you've got to kind of, there are some very big things we could get after, and let's go after the things that nobody, is a problem for everybody and nobody cares that much about. Again, if you're that, 21-year-old who's doing credentialing for Humana, they probably care, but I would rather do something more satisfying than chasing down rosters at every provider out there. So sorry to go on. I don't know if that really solves the problem, but it is an opinion about the work and where there's some collaboration and some common ground.
Yeah, well, it's a tough question. I mean, I think before we even get to collaboration across entities, I think this panel is representative of what needs to happen within the different sectors of healthcare. So as a top 12 healthcare system, I think Sutter Health has an obligation to the healthcare provider industry and to the country to get together with the other big systems and to try to start to at least agree amongst healthcare providers some of the things that Catherine was talking about. I mean, even at Sutter Health, I had a friend who was in an awful car accident. Actually, a deer went through his windshield into his back seat, and he was taken to a Sutter hospital in Santa Rosa. He's a PAMF patient. And because the electronic medical record, even within Sutter, does not talk to itself, we have to clean up our own backyard because the physicians that saw him in that hospital weren't aware that he was a PAMF patient. So he bounced around the system until he has the bat phone because he's got my cell phone number, and he called me and we got him in. So my point in bringing that up is there needs to be internal collaboration within entities and a stand taken from the payer space and the system space and the innovation space that Carter's representing at the high level across the country. And I think when those systems get their internal acts together, there can be this sort of reaching across the lines and cross collaboration amongst entities. Because to your point, Stefanos, it's so complex. We're not going to get there in absence of that.
Great. And I think what I'm hearing here, which I hope is inspirational for those in the audience, is looking for opportunities, even individual ancillary opportunities to simplify things, collaborate internally. If it asks for collaboration between entities with staying power, and by proving these smaller opportunities for simplification, you slowly build a case for broader simplification. So it's like continuous improvement, one step at a time, learn to walk before you run type of mindset.
And don't underestimate how much innovation can be unleashed when infrastructure is more streamlined. I bet you startups probably burn, 70+% of capital because every implementation is bespoke. And so we are massively wasteful in how we plug into the system because the system is so heterogeneous. I mean, it's just, there's no standardization to it. And so we're wasteful on the innovation side where we need it because we don't have a common ground. So even though they seem pedestrian, I just believe the unlock is huge if we get the basics right, because then we compete where we should compete. I think it's material.
Great, thank you. So I see people raising their hands, so I will start by getting questions from the audience.
Hi, thank you, Kristen Jacobson. This is a mind-blowing panel. Oh, hi, this is a mind-blowing panel. I have so many questions, and I know that lots of people do, so I'm going to try to have one. One of the things that I think is at the core of some of the things that Rashi talked about, and also Ken talked about, which is in order to get the standardization, how do you properly regulate? Because without proper regulation, it can't work. But nobody likes to be regulated. So the health plans are the first to not want the regulations, or the providers, or whoever has the drug. And part of the mess of credentialing is that every state has their own, and most health insurance is done state by state. And then at the same time, there's no way to get a standard unless you do something federally, which is almost impossible. So how do you find the balance? And just one example of how severe a problem can be. I personally have a huge problem with Medicare Advantage just because of my personal mom situation, that they basically tried to kill her, not on purpose, but they did because they were trying to align incentives so much that the managed care plan kept saying no after the doctors said yes, and so the doctors would change their recommendation. And I do this for a living. I appealed up to one level below the director of CMS, and there's no appeal for an early discharge. So without patients' rights and appeals, so it's all really, really complex, and it can go really right and really wrong. And your Sutter point, if I get a doctor's prescription from Stanford sent to Sutter, and I want it done at the Sutter lab, it's not that they don't even know it's in Sutter. It's one building in Burlingame, and if they fax it to one side, I cannot get my blood drawn at the other side, and none of it gets loaded into the system. So anyway, that's, and I'm just marveling and very curious about what you talked about on the drug side. That's fascinating.
So maybe just a quick comment, and really appreciate your thoughts. As an industry, and again, the complexity about state and federal is very real, right? All your commercial plans are regulated at the state level, Medicaid is state level, Medicare is a national program. So this complexity, again, not making any of this easier, but is real. And having spent a fair amount of time in DC, talking to legislators and to a lot of staffers, we all know what's happening in the political environment, right? We have a lot of turnover of and particularly in the House, a lot of turnover. And so when I go talk to folks about what a rule change the implication might be, I'm talking to the most recent 25-year-old who doesn't even hit the system, doesn't even know what it means. They've never even talked to their grandparents about what it means to be an aging person in America in the health care system. So to talk to them about the nuance of a policy change is very challenging. And so we've taken a position, and this is very true of change, right? If you want to be at the table, you better have an opinion and you better have an idea for change. And so, because I would rather decide how we're going to be regulated than let the most recent 25-year-olds decide how we're going to be regulated. So you have to come with proactive ideas. And again, it's not perfect. The political system is very messy. Healthcare has a very large, and particularly in public programs, is very, we got regulators, and they too have opinions and perspectives and incentives. And so I don't know that I'm answering your question. I'm just acknowledging that is another, we hadn't really talked about that, and that is another overlay that makes this complicated. So thank you for your feedback. It's not an answer. It is more around why this is complicated. I'm sorry.
Okay, thank you.
Yeah, go ahead. Sure.
Ken.
Hi, I too have a bunch of questions, but I'll keep it to one. It's for Mrs. Field, or Ms. Field. It's about insurance and why it works so differently in healthcare than any other line of insurance. So take life, take auto, take property and casualty. None of them pay for maintenance of life or maintenance of your car or maintenance of your property. You know, they are for insuring against catastrophic events. Why does healthcare insurance work as a maintenance of health tool rather than insuring against catastrophic health events?
We could take a whole another few hours on that, right? You know, and some of it comes back to just kind of how health insurance got its life here in this country. It's got something to do with our expectations about care. We want very broad. I was just actually yesterday I was at a meeting where Rob Allen, who's the CEO for Intermountain Healthcare, was speaking. He was kind of speaking to this topic in general. I don't tell your boss, I'm probably going to misquote him. But the point he was making is that there's no other kind of insurance that covers, car washes and I want my house repainted. And so we have this expectation, and it is this sort of mix between and the debate in our country about where does healthcare sit in terms of payment and universal healthcare. And there's just a lot there. The ACA, the types of benefits from an ACA in Medicaid. I think. So again, I'm not answering your questioning. I'm acknowledging that is a very true statement. And until I think somewhere there is going to have to be a reckoning with our personal accountability. And so you see it in the commercial space where employers are not going to pay for the level of insurance. They're going to be I think as more and more the spend gets bigger, employers are going to look at pushing more folks into ICHRA, into not providing insurance. I just think it's going to. We have to, and again, I don't know that high deductible plans are always the answer either, but they are more similar to other kinds of insurance because we want people to have access to care. It is not a good idea for people to go to the ER for their point of contact to go to access the system. So anyway, I don't know if you guys have any to add to that. Very complicated, but important question. Thank you.
Let's get one more question.
Hi. Where's the projector just in case? Hi, my name is Daniel Garcia. I'm an MBA candidate here at Stanford GSB. I'm mostly curious about the value-based care proposition. I'm thinking about how most people in the United States spend approximately 2 to 3 years on a health plan on average before they switch. Yet outcomes are a long-term game. Think about GLP-1s. You don't really see those gains on like heart attacks and other comorbidities of obesity until like 10, 20 years out. So how do you do value-based healthcare when the incentive is only to treat for 2 to 3 years because people are changing health plans so frequently?
So I'll speak briefly to
all the good ones.
in particular, the Medicare Advantage space, right? Because the commercial space is different, but and particularly in Medicare Advantage, because we have folks with very complicated and increasingly complicated healthcare status as we age, value-based care really matters. Aligning incentives really matters. One of the things that happens, and again, it's complexity, is as a company, we value consumers staying with us. The longer consumers are with us, the more we understand people's healthcare conditions, we understand their ability to access the system. So we can have more important interventions the longer people stay with us. So it is in our entire interest to make sure that we have stable benefits, that we are investing in our consumer, we're making it simple and easy for people to stay with Humana. So we would like people to stay longer, and so we're going to invest longer. It's still insurance in general, as people, in Medicare Advantage, you can choose a new plan every year. So I know I'm getting a time's up around here, but does that, at least in the short term, answer your question? We can chat out.
I'd love to hear Carter's and Catherine's thoughts on value-based care.
I mean, we could also spend an entire class on that. I mean, here's what I would say. The big challenge at a meta level with value-based care is you can't have a toe in it. You have to go all in. And so what I've struggled with at Sutter, at Stanford Healthcare, at the system that I was on the East Coast, is all systems want to lean in and take less of a foot off that fee-for-service horse. They really do, because it's better for patients, as Catherine was talking about, but it's really hard to do that. And so what you're seeing is incremental improvements over time, but it's not happening fast enough. So I am fascinated, and there are people on the stage who know much more about it than I do, but what I have consistently seen over 30 years of my career is the effort and the aspiration to do value-based care, pay doctors what they should get paid, provide the right care for patients over time, and lots of different systems going at it. Unfortunately, I can count on one hand, and I would be interested in both of your thoughts, the systems, the healthcare provider systems, who can say, we haven't solved the issue, but we are making more than incremental progress around all of this. And you just pointed out one of the reasons as to why it's so hard. I don't know if that's helpful, but that's just been my experience.
Yeah. Maybe just the complexity within a systems mix, right? How you care for Medicaid looks really different than how you care for commercial than you do for Medicare Advantage. Kind of, because we're all different humans at different ages of our life. And so being able to be all in on all of your lines of business in the Medicare, in the pay for outcomes model is very hard. It is a little easier because, again, there's just a lot more care coordination and support needed for our aging population.
I think that was kind of that differential point that I was going to make. I mean, for many years, we talk about when do we get to the tipping point? When do we get to the tipping point? And I think talking about a tipping point in aggregate is elusive because there are so many different populations, so many different institutions you're working with. But if we can start to distill it down, back to the simplicity, where do we have patient populations where we have a relative tipping point that we flip the whole switch? Even if we can't do it for everyone, there might be a Medicaid population where that care, an insurer in that market has density, you have it, you flip. And so you can start to get relative tipping points, and then in your endurance, so Intermountain is a fully integrated system, and we actually have a longer duration within our providers. So we actually see when we did studies on this, and we could see that we had a much longer duration with those when we had the connection across both. So anyways.
Great. Well, please join me in a big round of applause for our great panelists.